Welcome back to the deep dive. If you're a medical student gearing up for that all-important ENT rotation, or, a clinician just looking for a really high-yield refresh, then this is for you.
Absolutely. We've gone through the source material to pull out the absolute foundational knowledge you need.
Our mission today is to build you a high-impact clinical playbook. We're talking core anatomy, common infections, diagnostics.
And the pharmacology that ties it all together. We want to deliver it with scientific rigor, but in a way that actually sticks.
Exactly. So let's jump right in. We're starting with otology, the ear, specifically anatomy and diagnostics.
Right.
Let's begin with the external auditory canal, the EAC. It seems simple, but its structure is key to understanding where certain infections can and can't happen.
It is deceptively important. The whole canal is about 24 millimeters long, but it's split into two completely different segments.
Okay.
The outer 1/3, maybe 8 millimeters, is cartilaginous. The skin there is thick, and this is the crucial part. It has hair follicles and ceruminous glands.
The glands that make earwax.
That's them. Now, the inner 2/3, about 16 millimeters, is bony. And the skin there is paper thin, stuck right to the bone.
And no hair follicles.
Zero. No follicles, no glands. Completely different environment.
And that one anatomical fact has an immediate clinical payoff, right? I'm thinking of furuncles.
Exactly. A furuncle is just a painful staph infection of a hair follicle. So if there are no hair follicles in the inner 2/3,
They can only happen in that outer cartilaginous part. It's a huge diagnostic clue right from the start.
a perfect example of anatomy dictating pathology.
Okay, moving inward to the middle ear. It's this tiny air-filled box with, 6 walls?
6 walls, and we usually think of it in 3 parts. The epi, meso, and hypotympanum. The walls are named for what they're next to. So the roof is the tegmental wall, separating it from the brain.
Right, and then you have the jugular wall on the floor, the carotid wall on the front.
Exactly. Mastoid, labyrinthine, and the eardrum itself, the membranous wall.
I often hear clinicians talk about Prusac space, especially with chronic ear disease. Where is that exactly?
Prusac space. It's a tiny but critical pocket. It's in the lateral most part of the epitympanum, just above the floppy part of the eardrum, the pars flaccida.
And why is it so important?
It's a notorious starting point for acquired cholesteatoma. It's a hidden area where things can get ugly fast.
And you can't talk about the middle ear without the Eustachian tube. This explains so much about why kids get so many ear infections.
The difference in anatomy is just stark. In an infant, the tube is way wider, it's shorter, and most importantly, it's almost completely horizontal.
It's like a direct highway from the back of the nose into the middle ear.
It is. It's a straight shot for bacteria and reflux material. The adult anatomy, which is angled downwards to drain properly, doesn't fully develop until a child is maybe 7 to 10 years old.
That leads us perfectly into chronic suppurative otitis media, or CEASE. This is a must-know distinction for any learner. There are 2 types.
Right, and they couldn't be more different in terms of risk. The first is the tubotympanic type. Think of this one as safe.
Safe, okay. What makes it safe?
Generally, it involves a central perforation in the main part of the eardrum, the pars tensa. The discharge is usually watery or mucoid. It's a mucosal disease, not a bone disease.
And the dangerous type?
That would be the adicoantral type. This one is unsafe. Here, the perforation is marginal right at the edge, or up in the attic, the pars flaccida.
And the danger here is its link with cholesteatoma.
That's the one.
Let's define that term properly. It's not a cancer, right?
Not at all. People hear oma and think tumor. It's actually a collection of skin keratinizing epithelium that's trapped in the middle ear where it doesn't belong.
And the problem is that it sheds skin flakes, the keratin builds up.
And it triggers an inflammatory reaction that releases enzymes. And these enzymes literally dissolve the surrounding bone, the ossicles, the mastoid. It's incredibly destructive.
There's a clinical rule of thumb here, isn't there? Something about ear polyps.
A critical one. If you see an ear polyp in an ear with chronic discharge, you must assume it's hiding a cholesteatoma until you prove otherwise.
Got it. Okay, let's switch to diagnostics. Hearing assessment tools. We have to start with the tuning forks.
The basics, Rhin and Weber tests. With the Rhin test, you're just comparing air conduction, AC, with bone conduction, BC.
And what's normal?
In a normal ear, AC is much louder and seems to last about twice as long as BC. Simple as that. It helps you quickly sort out conductive versus sensorineural loss.
And for a more objective look, we have tympanometry.
Right, impedance audiometry. It's basically measuring the stiffness of the eardrum system as you change the pressure in the ear canal.
What's a key number to look out for?
If you see a middle ear pressure below minus 150 millimeters of water, that's a really strong sign of poor Eustachian tube function. It means there's significant negative pressure.
And you can also use it to check if a grommet, a ventilation tube, is working.
Exactly. It's called the inflation-deflation test. It confirms the grommet is patent or open.
Okay, what about the acoustic reflex? It's a bit more complex.
It is, but it's a great test of the whole pathway. A loud sound, maybe 70 to 100 decibels above their threshold, causes the stapedial muscle to contract on both sides.
Bilaterally.
Yes. The signal goes in through cranial nerve 8 to the cochlear nucleus. It crosses the brainstem at the superior olivary complex.
And then the go signal comes back out through the motor part of cranial nerve 7, the facial nerve.
To the stapedial muscle, you got it. It's a beautiful reflex arc.
And for that whole ascending pathway, there's a great mnemonic.
Yes, ecolema. It stands for 8th nerve, cochlear nuclei, olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body, and finally, the auditory cortex.
Ecolema, perfect for localizing where a problem might be.
It's incredibly useful.
All right, moving from the ear to the nose and sinuses, the physiology of the nose is just amazing. It's so much more than a breathing tube.
It is our body's primary air conditioner. I mean, we are natural nose breathers. That's why a condition like choanal atresia in a newborn is a true medical emergency. They can't breathe.
And what about that air conditioning function? How does it warm the air so quickly?
It's this incredible radiator mechanism in the turbinates. They have these highly vascular, cavernous, venous spaces that act like heat exchangers.
So they can warm freezing cold air to body temperature almost instantly.
To near 37 degrees Celsius, yes. And for humidification, the numbers are staggering. About 1 liter of water is evaporated from the nasal mucosa every single day.
A whole liter. Wow. Of course, that rich blood supply has a downside. Epistaxis or nosebleeds. Where's the usual culprit?
The hotspot is Little's area, on the anteroinferior part of the septum, also called Kieselbach's plexus.
And it's a plexus because it's a meeting point for a bunch of arteries, right?
Exactly. It's an anastomosis. You get branches coming in from the external carotid system, like the maxillary and facial arteries, and also from the internal carotid. It's just a very fragile, very vascular area.
Okay, shifting to sinusitis. Let's talk about the maxillary sinus and its relationship with the teeth.
This is a classic anatomical trap. The floor of the maxillary sinus is formed by the alveolar process of the maxilla, where the teeth sit.
And the roots of the upper molars and premolars are right there?
They often project right up into the sinus floor. Sometimes they're separated by only a paper-thin layer of bone, and sometimes there's no bone there at all.
So a tricky tooth extraction.
Can easily create an oroantral fistula, a direct hole from the mouth into the sinus. That introduces all the oral bacteria, and you've got instant maxillary sinusitis.
From infection to allergy. Allergic rhinitis. We need to be specific and call this a type I hypersensitivity reaction?
Yes, it's the immediate IgE-mediated type. It's a two-step process. First, you get sensitized, and your body makes IgE antibodies that stick themselves all over your mast cells.
And then when you encounter that allergen again,
the allergen acts like a key, bridging two IgE molecules on the mast cell surface. That cross-linking is the trigger. The mast cell degranulates.
And releases that cascade of histamine, leukotrienes.
Prostaglandins, you name it. And those chemicals are what directly cause the runny nose, the swelling, the classic allergy symptoms.
It's also so important to remember that nasal symptoms can be a sign of a bigger systemic disease.
Absolutely. The sources point to a few key ones. Wegener's, which we now call granulomatosis with polyangiitis. Sarcoidosis. Leprosy.
And for sarcoidosis, the key differentiator from something like TB is the lack of what?
Caseation necrosis. You see granulomas, but they are non-caseating. That's a huge histological clue.
Okay, let's move down to the pharynx, larynx, and airway. Acute tonsillitis. The bug here is simple, but the stakes are really high.
Very high. The most common bacterial cause is group A beta hemolytic strep. And the reason we care so much is not the sore throat itself, but the risk of the non-suppurative sequelae.
Rheumatic fever and glomerulonephritis.
Exactly. Which can cause lifelong heart and kidney damage. So you have to identify and treat strep throat properly to prevent those devastating complications.
A huge topic now is obstructive sleep apnea, OSA. This is more than snoring. What's the core pathophysiology?
It's a combination of anatomy and physiology. During deep sleep stages 3, 4, and especially REM sleep, all your muscles relax.
Including the muscles that hold your airway open.
Right, like the genioglossus muscle in the tongue.
Yeah.
So the airway becomes floppy. Then, when the person tries to breathe in,
They generate this powerful negative suction.
and if their airway is already narrowed by, say, big tonsils or a deviated septum, That negative pressure just causes the walls to collapse completely, and that's your apnea event.
And the gold standard for diagnosis is the overnight sleep study.
Polysomnography, yes.
Yeah.
It measures everything: oxygen levels, breathing effort, brain waves, to give you an apnea-hypopnea index, or AHI, which tells you how severe the OSA is.
Moving down to the larynx itself. Two cartilages everyone should know.
The cricoid. It's the only complete ring of cartilage in the airway. Narrow in the front, broad in the back. And the epiglottis, the leaf-shaped cartilage that protects the airway when you swallow.
And for voice function, what controls loudness versus pitch?
Loudness is just air pressure from the lungs. More pressure, more volume. Pitch is frequency, and we control that by changing the length, tension, and thickness of the vocal folds.
When you're thinking about laryngeal cancer, understanding the spaces is key for staging. Where does a tumor of the ventricle tend to go?
It likes to invade the paraglottic space. That's a deep space next to the vocal cords. Once a tumor gets in there, it can spread transglottically, meaning across the different levels of the larynx, which makes it much harder to treat.
And the big red flag symptoms for laryngeal problems are stridor and hoarseness.
Absolutely. Stridor, that noisy, high-pitched sound on inspiration, is a sign of major upper airway obstruction. In an adult, you have to think malignancy first.
And hoarseness.
Any hoarseness that lasts more than 3 weeks in an older patient, especially a smoker, is vocal cord cancer until proven otherwise. You cannot delay that workup.
Okay, final section. The pathogen playbook and some pharmacology, fungal ear infections, automycosis. Does it matter where you are in the world?
It does. It's a superficial infection of the EAC. In temperate climates like ours, you tend to see more candida. But in tropical or subtropical regions, Aspergillus niger is the more common bug.
And what about fungal sinusitis? When does that become a true emergency?
It becomes life-threatening in the immunocompromised. A patient with uncontrolled diabetes, a transplant recipient, someone with AIDS. They're at high risk for invasive fungal sinusitis. It's a necrotizing infection that requires incredibly aggressive surgery and antifungals.
We should also touch on viruses and sudden hearing loss.
Yes, for sudden sensorineural hearing loss, a viral cause is often suspected even if we can't prove it. The list includes things like rubella, mumps, measles, herpes zoster, CMV, and influenza.
And thinking about influenza, what about pandemic H1N1 or swine flu, the main antivirals?
Oseltamivir and zanamivir. And the key was always to give them early, within the first 48 hours, to really have an effect.
Okay, let's wrap with some high-yield antibiotics, penicillins and Staph aureus. Why doesn't standard penicillin work anymore?
Because most Staph aureus strains now produce an enzyme called penicillinase. It's like a little pair of scissors that just chops up the penicillin molecule before it can work.
So for a non-MRSA staph infection, you need something like
A penicillinase-resistant penicillin, like flucloxacillin, or we use immunopenicillins, like amoxicillin, which give you better coverage against gram-negatives like H. influenza.
Lastly, the cephalosporins. They're broad spectrum, but what are the big things they don't cover?
Every clinician needs to know this. The mnemonic is MALE. They don't cover MRSA, atypicals like chlamydia and mycoplasma, listeria, and enterococci, MALE. If you suspect one of those, a cephalosporin will fail.
This has really highlighted how everything in ENT is connected. You see how Eustachian tube dysfunction leads to negative pressure, which leads to a retracted eardrum, which sets the stage for cholesteatoma.
It's a perfect chain reaction. And the take-home message for you as a learner is that you have to correlate what you see with the underlying pathophysiology.
Knowing the difference between a safe central perforation and an unsafe marginal one
Is everything. It's a single glance that completely changes your management plan because one is about bone destruction and the other is just a mucosal issue. That knowledge makes you a safe and effective clinician.
To really drive this home, let's end with a short clinical exercise for you to think through.
Okay, here's the scenario. A 65-year-old patient with poorly controlled diabetes comes into the ED. He has excruciating pain in one ear and a foul-smelling discharge.
On exam, you see granulation tissue filling the ear canal.
So based on what we've covered, what's the most likely diagnosis? What's the bug? And what's the most feared complication?
We'll give you a second. The diagnosis is necrotizing or malignant, otitis externa, a skull base infection.
The causative organism is almost always Pseudomonas aeruginosa. And the major complication is the infection spreading along the skull base and knocking out the facial nerve cranial nerve 7 as it exits the stylomastoid foramen, causing a facial paralysis.
If you piece that together, you are in excellent shape for your ENT rotation. That's all the time we have for this deep dive.